Okay, so the next thing we'll talk about is hemolytic disorders of the newborn. Hemolytic disorders are usually because of a blood type incompatibility. Remember that maternal circulation goes into the lake below the placenta, but it does not actually cross into the fetal body, and the fetal blood does not cross into the maternal blood under normal circumstances. So they can have two different blood types. So occasionally in the process of birth, or if there's some kind of trauma, if the placenta is disrupted and fetal blood gets into the maternal bloodstream, then we can have a blood reaction. So if the mother's blood type has antibodies against the fetal blood type, that's going to attack the fetal red blood cells and cause clumping and breakdown of those red blood cells. That causes severe anemia and hyperbilirubinemia. So Rh incompatibility is typically the most severe type of blood incompatibility. If an Rh negative person will form antibodies if they're exposed to Rh positive blood. So an Rh negative mother, if they have an Rh positive fetus and something happens to allow that fetal blood to get into the maternal bloodstream, the mother will make antibodies against that Rh positive blood. Okay, antibodies can cross the placenta, and so those antibodies against the Rh positive blood attack the red blood cells of the fetus. So in utero, that can actually cause severe anemia and hydrops, which again is like congestive heart failure for the fetus. It can cause intrauterine fetal death if it's severe enough in utero. But sometimes if that baby is born, they may be born and they still have maternal antibodies that are attacking all their red blood cells, and that's hemolytic disease of the newborn. So we're more likely to get fetal blood into maternal circulation and start making those antibodies if there's multiple gestation, if there's an abruption, placenta previa, manual removal placenta, or cesarean. Usually when this happened, it was not the first baby that was affected, because usually that exposure happened at the time of birth. And so that baby's already out and isn't affected by those antibodies. But if that mother becomes pregnant a second time and they're already sensitized, they already make antibodies against Rh positive blood, those antibodies cross the placenta and they attack the red blood cells of the fetus. Okay. We can also see some effects of this with ABO incompatibility. The hemolytic reaction is usually less severe than Rh incompatibility. What does this look like? In utero, we may have erythroblastosis fetalis, which is the fetus trying to compensate by making more red blood cells. It puts immature red blood cells in circulation. The anemia gets so severe that the baby's in a type of heart failure called fetal hydrops. They're hypoxic. They have a lot of swelling. They have fluid effusion into the pericardium, into the pleural space, into the peritoneal space. It can result in intrauterine fetal death or severe respiratory distress at birth. Okay, so we can see this actually in utero and have a very, very sick fetus. If the baby's born without intrauterine complications, we might see jaundice within the first 24 hours because all of those red blood cells are being destroyed by the antibodies. We may see a really rapid rise in bilirubin levels, and that bilirubin can get high enough to cause neurologic damage. We would see severe anemia. The spleen and liver may be enlarged. trying to deal with all of these broken down red blood cells. The baby may have anasarca, which is generalized edema. They may be pale. They might be in hypovolemic shock, because without all those red blood cells, the fluid in the blood goes out and causes edema. They may be hypoglycemic, and they would have a positive Coombs test. Management is prevention. We want to prevent this. This is why RhoGAM is given. Anyone who is Rh negative who is pregnant should get a shot of RhoGAM at 28 weeks after any potential trauma, after delivery, miscarriage, or abortion. Okay. At any opportunity for fetal blood to get into the maternal system, they need a shot of RhoGAM. That prevents the maternal system from making antibodies against the fetal blood type. If we have severe intrauterine effects, they can actually do an intrauterine transfusion. They access the umbilical cord through the abdominal wall. That's not super fun, and they can do a transfusion. Newborns, sometimes they would give IVIG, but there's no evidence that that's helpful. Phototherapy helps them deal with the jaundice. So if they're born and they have jaundice within 24 hours, they're getting phototherapy. Because remember, part of the complication of this is jaundice. If they continue to have antibodies and break down their blood cells, and they're not able to maintain red blood cells, then they might do an exchange transfusion, in which a little blood is removed, a little bit is infused, a little is removed, a little is infused, until they've basically exchanged the baby's entire blood supply and removed the antibodies. Okay, we have 2 more sections on this lecture. We're getting so close.